Good afternoon, everyone. My name is Aisha Usman. I work at the Mental Health Foundation Australia, and I'm your host for today's webinar. We begin by acknowledging the Wurundjeri Woi-wurrung people as the traditional custodians of the land on which our office stands, and pay our respects to their elders, past and present. We extend that respect to any Aboriginal or Torres Strait Islander peoples tuning in today. On behalf of the Mental Health Foundation Australia, I would like to welcome and thank each one of you for attending today's Lunch and Learn educational webinar on Autism Spectrum Disorder in Children, presented by Emeritus Professor Bruce Tonge. Before we begin, a disclaimer that this webinar is intended for educational purposes only and should not be relied on as personal advice. Please seek the guidance of your doctor, psychologist, or other qualified health professional regarding your physical or mental health. Our today's webinar will focus on early infant development and behavior, and early intervention for neurodevelopmental problems such as autism. Careful observation of early infant development and behavior is the best opportunity to see the signs of potential neurodevelopmental difficulties such as autism. Early intervention, early in life, leads to best outcomes. This webinar will describe the characteristics of an autism spectrum disorder in young children and other associated behavioral and emotional challenges that may face the young child and family. I would like to introduce our presenter, Emeritus Professor Bruce Tonge. Professor Tonge has a distinguished record of clinical work, teaching and research in child psychiatry. Prior to his retirement, he was foundation head of the School of Psychology and Psychiatry and head of discipline of psychological medicine at Monash University. He established the internationally recognized Monash University Center for Developmental Psychiatry and Psychology. He continues to have clinical, research, and teaching interest in developmental psychiatry, with a particular focus in the areas of autism spectrum disorders and behavioral and emotional disturbance in children and adolescents with intellectual disability and neurodevelopmental disorders. Please join me in welcoming Emeritus Professor Bruce Tonge.
Well, thank you for the introduction, Aisha, and it's good to be with you all. Now, in fact, where are we going to start today? We're going to start to look at the very beginnings of life, at early childhood. And I will share my screen so that we can work through this. Having a child is one of the most wonderful things available to human beings. And if you've been fortunate enough to be a parent, you'll know the wonder and mystery of this, but also the challenges and the anxiety and sometimes the perplexity of being a parent. It's not easy, but it's also wonderful, mostly. When we are fortunate to have a young child in our family, they bring us lots of joy, but also at times lots of worry, particularly if you are a parent for the first time. How do you learn about being a parent? What have you got to go on? How do you know about this tiny child in your arms and what their movements and sounds mean to you? As the child gets a bit older, of course, they also challenge us. And so what I'm going to start with is the importance of the beginnings of life, of early childhood, and how you make sense of it. Now I'm having trouble moving my screen onto the next slide, which I do apologise for. I think I'm going to have to stop sharing. We're going to have to try this again. I do apologise for this. I'm screen sharing and I'll move on to the next slide. I apologise, it's not...
Professor, you can try pressing the right arrow key in the keyboard to move through the slides.
Yes, that's what I'm doing.
If it's not working, I'm happy to share.
I think we'll have to hand over to those who are much more competent than me at managing technology. I'll stop sharing. There we go.
Just a moment, I'll just bring that up.
I'm a bit like a parent with a new child, not quite sure what to do next. Here we go. There we are. Now, in fact, I'm in a different part of the country talking to you. I'm on the traditional lands of the Juru people in far north Queensland, and I pay my respects to their elders past, present and emerging, and to any Aboriginal and Torres Strait Islanders with us today. We're indeed privileged to have your attendance. Next slide, please. So we begin early in life, and careful observation of early infant development and behaviour is the best opportunity to see the signs of potential neurodevelopmental difficulties such as autism and intervene early to promote the best outcomes. Now, we know in fact that at least half of all new parents have worries about, is their baby right? And of course, mostly they are. Now, parents worry about sounds they make. Are they sleeping too much or not enough? When should they be starting to look at you? What does that gurgle mean? Is it the beginnings of the child trying to say mama or dada? So it's very common to have worries about, is my little baby developing properly? Now, fortunately, we have, at least in Australia, a very extensive service of early surveillance and care and help available for mothers and fathers with new babies. And it's our maternal and child health service network. It's very important to get to know your maternal and child health nurse because they know about babies and they can reassure you and they can help you travel forward to know how your baby is going. Now, in fact, sometimes there are some worries that might be significant. In other words, act as a flag to tell us that perhaps the child's development is going on a pathway which is not quite regular or normal. And I'm going to give you now, in the next slide, some red flags that we look for in children that perhaps might have autism. And I stress might have. This isn't a diagnosis of autism. There are lots of other reasons why a little baby might behave like this. But there's no shame in talking to your maternal and child health nurse or your general practitioner or another child care worker about what these signs might mean and get help early. The first of these red flags is that the baby mightn't babble or coo by 12 months. In other words, make vocalizations, blah, 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 coo, coo, little sounds, vocalizations. Now, there could be lots of reasons for that, but the potential for autism is one of them. Perhaps the baby might be deaf. Perhaps they might have had a hearing infection or an infection in their ears. There are a number of reasons why they mightn't babble or coo, but it is a sign to ask for help. Another red flag is if the child doesn't make gestures with their hands. For instance, point at something or wave or reach out to grasp. In other words, a very early way that babies communicate is through their hands and gesture and the movements of their body. For example, when they see you come into sight, they might suddenly shake with anticipation. In other words, they might make a gesture on their face. They might smile. They might break into a giggle. And by 12 months, infants should be doing these things. They should be gesturing, not talking, but talking, if you like, through their hands and their body. If the baby isn't gesturing by 12 months, have it checked out. Another red flag for autism might be that the child is not saying single words by 16 months, not just blah, 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 babble, but a word like cat or mama or doggy. And these words are quite clear. And once they're said, they're usually then repeated, and you soon get to know that they mean something, that they have a meaning. So if the child's not saying single words by 16 months, that's a sign to have them checked. We also know that children should be saying two-word phrases on their own rather than just repeating what someone says to them by 24 months. Now, sometimes earlier you might say, "Who's a good girl?" And the child might say, "Good girl." That's a repetition. What we're talking here about is independently initiated two-word phrases by the child, like mummy drink, meaning mother, can I please have a drink? Or daddy, look, when the father comes into the room. In other words, it's a phrase with a meaning, it's a communication, and it occurs by 24 months. And of course, rapidly after that, language develops. Another early sign for autism is if the child has any loss of any language. It doesn't matter what language it is, what language they're speaking. For instance, in the family, they might speak English and Parsi, and the child develops some language in either of those languages and they lose it quite suddenly. That's a red flag. The other thing that happens is that during those first 12 months, children start to develop social connection. They point when someone comes into the room and look at the other. For instance, the mother's in the room, the father comes into the room, the baby points towards the father and says, ooh, points, but looks at mother. In other words, there's a social skill developing. Mummy, look who's come into the room. Or quite early on, children start to play. For example, mothers will recognise that babies even play around the wonderful experience of breastfeeding. They might stop sucking until the mother says, what are you doing? And then they'll start again and then have a little giggle. And they play with objects. They may play with mobiles above their cot and so forth. And that's a social skill. So any loss of any language or social skill at any age is a red flag. So these are important messages. Now, so with that, you go to your maternal and child health nurse or your GP or another early childhood worker, and they look at this and say, look, I'm not sure what's going on, but there are some things to puzzle about in what's happening. So I'm going to organise for you to go and see the paediatrician or a local psychologist or a local early child intervention service for an assessment. And an appointment will be made, sometimes, unfortunately, still with a bit of a wait, but in the meantime, the maternal and child health nurse will be organising help for you from early childhood workers. And so at last, the assessment comes. Next slide, please. Now, what does this entail? Well, ultimately, it's a multidisciplinary one. That is, it involves a number of specialists in child development. There's usually a paediatrician or a child psychiatrist. There may be a speech pathologist who's an expert in language development, an occupational therapist who's expert in the development of play skills and motor skills, a psychologist who also knows about child development, and a special educator who knows about the way little children learn. And then a number of things happen. Firstly, the child may have a medical assessment, including various tests for developmental delay. So there may be a blood test, There may be a test of the child's hearing and vision, and perhaps some other things. You'll also meet a clinician who'll interview you to find out about the child's early development and the family history and what you're concerned about. There'll also be an observation of the child's behaviour and interactions. For example, the 3-year-old may enter into a play session which is structured with the psychologist, and that can form a special test, perhaps to look for the signs of autism. There's also what we call a developmental assessment, and these use standardised tests so that we can look at the child's performance compared to other children. Now, there are various types of developmental assessments, such as a psychoeducational profile, or a Bailey scales, or a Wechsler scales of cognitive development. Hopefully, there'll always be a language assessment looking at how the child is expressing language, how the child is understanding language, and how they're using language socially. That's what we call pragmatic language. The child's emotions and behaviour will also be assessed, talking with the parents about it, asking the teacher or preschool teacher or a daycare staff to complete checklists on their behaviour. Sensory problems will be assessed usually by the occupational therapist. That is, does the child react sensitively to things like sound and touch, and what's their motor skills and coordination like. So there is a number of observation and reports from parents, caregivers, teachers, and others who know the child well. In other words, we have to form a broad picture of each child so we get it right. It's an important diagnosis to make. It leads to development and the best chance for the future, but we have to get it right if we can. And we also have to talk sensitively with the parents and carers about what we think is happening. What are the explanations for the child's developmental difficulties? That's the first step in developing a plan of intervention and the services that are required. And fortunately, we've got a number of these now, and increasingly so in this country. So it's good news for these children and their families who have developmental problems. Next slide. Thank you. So let's say we think the child has autism. What do we mean by this? What is it? Well, it's not magic, really. It's a range of behaviours and symptoms that affect the child's development, that are based on the way their brain functions, and it involves two major areas of our life. Firstly, our social interactions, the way we interact socially, and the way we communicate with others socially, our social communication skills. Secondly, it involves what our behaviour is, what our interests and activity are, and in particular, in a child with autism, these are often restricted and repetitive. Now, these symptoms must be present from infancy or early childhood, and that's why we look for red flags. We can pick up the possibility of autism in the first year of life. But it may not be fully manifest until social demands exceed the limited capacities of the child socially. In other words, there are some children who seem to be getting on very well in their families. They do have red flags for autism, but they're being cared for. They're doing well in many ways, but it's not until they get to preschool and come up against interacting with other children that their social difficulties might become very obvious. The other thing is that sometimes the features of autism may be masked by a number of learned strategies. And we know that this is particularly so maybe in some females who during their childhood in the environment of family care and in the presence of intellectual capacity have masked their social and communication difficulties. And they may become only more apparent when they get moving on towards adult life. And of course, the degree of parental support that a child receives can also compensate for some of their autistic symptoms. So the fact that a child isn't picked up really early is a pity, we need to intervene early, but there are some very appropriate reasons as to why that may not be the case. But it comes back to being sensitive and alert to those early red flags. Don't deny them. Have it checked out. Autism also limits and impairs everyday function. In other words, it is a disorder. There's a phrase, oh, we're all a little bit autistic. I don't know quite what that means. It means, yes, we're all alive. We all have sensation. We all have social interactions and social communication. But when we're talking about autism, we're talking about these problems becoming so obvious and difficult that it impairs everyday functioning. And therefore, help is needed, intervention's important, and, for example, support by the National Disability Insurance Scheme is justified. Next slide, thank you. So let's look at these in turn. The first part of the autism duo are social interactions and social communication. And children with autism must have all of these symptoms. Firstly, they must have deficits in social and emotional reciprocity. By that, I mean they have difficulty interacting with other people socially. Now, there you can see at the bottom of that balloon, a mother sitting with her son, and he is engrossed in putting some blocks together. She is trying to interest him by showing him one of the blocks. He is ignoring her. Now, that by itself may not be abnormal, but if it's like that most of the time, then there's a problem. And this particular child was very locked into his own world. It was very hard to make contact with him. And you could imagine how distressing that was for a caring mother and father who loved their child and wanted to help. So that's one aspect of a deficit in social and emotional reciprocity. These children don't know how to engage easily with other children. They may rush up to a group of little children as if to join them, but then nothing happens and the children move away and the child is left perplexed and wondering what to do next. They may have difficulty, in other words, in knowing that there's a social world out there with which they can respond and get interactions and gain joy and learning. The second issue socially is deficits in non-verbal communicative behaviour to elicit social interaction. Now that little child there is pointing. That's a gesture. But we've got to look at what is the purpose of the point. Now, this particular child is pointing at something he wants. It might be, say, a banana. Now, that's communicative, and at one level, it is used for social interaction because the mother or father will get the banana and give it to him. But he doesn't use that to actually initiate ongoing social interaction. In other words, he's not using that point to generate social play or conversation or sharing something. For example, if he points at the banana and then looks at the mother and the mother gives him the banana and he then opens the banana and shares it with the mother, in other words, to eat together, that's a non-verbal communicative behaviour for social interaction. So it can be subtle, but it can be very real and devastating. A lot of children with autism early on have no expression on their faces. And that's culturally determined to some extent, our social expression on our faces, but all cultures use their faces to communicate socially. And these children don't give cues to invite people into their world by their face. And one way that sometimes happens is by a lack of eye contact. They don't use their eyes to look, like I'm using my eyes to look, hopefully, at you, those of you who are listening. The third area of social difficulty is deficits in developing, maintaining and understanding relationships. In other words, these children have difficulty understanding that other people have thoughts and feelings. They have difficulty in knowing how to respond when a member of their family might be upset or need help or comfort. And there's a child who is all locked up within himself, and he's retreated into himself while there's a big activity going on with other children around a game. He doesn't know how to continue to maintain these relationships. So that, in a nutshell, are the social interaction and social communication difficulties. There are more of them. I haven't listed all, but I hope that gives you an understanding of that arm of the diagnosis of autism. Next slide, thank you. Now, these are the so-called restricted repetitive patterns of behaviour, interest or activities. Now, children don't have to have all of these, but they need at least two. The first is stereotyped or repetitive motor movements, use of objects or speech, and that is where the child does something over and over. Now, it might be flapping their hands over and over. It might be pacing back and forwards. It might be shrugging their shoulders repeatedly. In other words, it might be a motor movement. It might be a repetitive speech. It might be something that you think is communicative, something like, how g'day, how you going? Now, that's very Australian, isn't it? How, good day, how you going? But if the child keeps on saying this out of context, and it's not communicative. And quite often we call this echolalic too, meaning an echo of what they've heard. So some of these repetitive speeches might be, for example, a repetitive sentence from a favourite children's cartoon like Bluey or something. The child says over and over what they've heard in the video or the cartoon, and it's not in a useful way. It's just out of the blue and they repeat it for no real reason. The second repetitive behaviour might be an insistence on sameness or adherence to routines or ritualised patterns of behaviour, of verbal or non-verbal behaviour. Now, there are a number of these, and the picture there is of a little boy who loved stacking things. And here he is, his mother's put all the canned vegetables and food in a low cupboard for his fun and games. She uses them to cook as well, but what he loves doing is going to that cupboard, opening the cupboard and stacking the cans of food. And he does that over and over, and it can be inflexible because if the mother then later on tries to demolish the tower, he can get very upset because he does not like change. There's an insistence on sameness. These children can have difficulty, for example, moving on from one activity to another. We call that a transition, a change. They like to get stuck on what they're doing. They may have difficulty finishing. They may have routines like a very specific bedtime ritual that if that's broken, they can get very distressed. They can be very inflexible in their behaviour. Now, this is a very complex part of the diagnosis, this particular insistence on sameness and inflexibility, and it can affect us in all sorts of ways. Some of it's very obviously unusual, and some of it may be more subtle. They get stuck on detail. The third area is highly restricted fixated interests that are abnormal in intensity or focus. Now, some of these on the surface may seem to be normal. For example, the child might be fixated on toy trains and railway tracks, Thomas the Tank Engine, for example. And that's fine, that's what children play. But a child with autism will be so fixated on that, it's all they focus on. The game doesn't necessarily elaborate. They may not tell an imaginative story about that. They may just build the railway track, and watch the train closely with their eyes going around and around. And if they're interrupted, they become very upset. In other words, this interest can be very intense. Another interest at the moment is fixated on what can happen on a screen, perhaps on a computer game. Now, you might say, well, isn't that normal? Most children like computer games. Yes, that's true. They do. But this fixation consumes them to the expense of all else, even sometimes being able to come for meals. And it can become a source of great conflict between parent and child if not handled early and correctly. The third area is what we call sensory sensitivities. This is where the child is either over or under reactive to various sensory inputs, like, for example, sound. This little boy here is very distressed when he hears various noises, like, for example, taps running, or the vacuum cleaner running, or perhaps the noise that the back door may make when it squeals to shut. They may be interested or underinterested in sensory inputs in the environment. For example, some children with autism are very alert to light. They may study mirrors, or they may look at lights, or they may get down closely to their toys to see the shadows and the light shining on the surface of their toy train. Sensory aspects cover a wide range of our behaviours because, of course, we're very sensate organisms, and these children with autism usually have some sorts of sensory sensitivities. Next slide, please. So that's autism. That's it in a nutshell. And you might say, oh, well, all right, the child's diagnosed, here it is, off I go, and we'll deal with it. But what I want to get across today is that is not all we must think about when we think about a child with autism. Unfortunately, sometimes parents tell me that they have experiences of having assessments, and yes, their child receives a diagnosis of autism, and yes, they tick off in the social and the repetitive behaviour domain, and that's it. Goodbye, here's the report, off you go. That's no good, because the child is much more than just a child with a particular neurodevelopmental profile we happen to call autism spectrum. We must think as well in an assessment about the whole child, their biological makeup, that is their physical and their health makeup, their psychological makeup, that is how they think, what their intelligence is like, how they use their thinking, and their social world, the social world in which they exist and the way in which they interact with that. And in particular, there might be cultural contexts to that. So we must think about the whole child. And I'm going now to go through a series of issues about the whole child that we take into account when we're doing a comprehensive assessment in order to plan for early intervention. Next slide. The first thing we need to think about is the child's intelligence and cognitive ability. That is their capacity of their brain to work. Now, our brain's a very complex matter. If you like, it's dozens and dozens of different computers, all doing different tasks and all linked together. Now, what we often find in children with autism is that their thinking capacities are very scattered. Firstly, let's look at the child who is represented by the black line at the top of this diagram. Now, this child at their chronological age, let's say they're 3 years of age, are bright and intelligent. Their language is developing, their receptive language, that is their understanding of language. They have motor skills, they have social skills, and they have daily living skills, meaning they're developing a capacity for toilet training, they're developing a capacity to use their bodies and to do jobs like help mummy with the dishes. Now, if you look at this child with autism, you'll see that their developmental profile, their cognitive ability is scattered. With most children, it's fairly even. Their thinking capacity is very good. It's at their chronological age. In fact, we would say they're of normal intelligence. But their expressive language, their capacity to use language expressively, is less than their chronological age, as is their receptive language. Their motor skills are not too bad. In fact, they can stand on one foot, they can hop and jump, and they can catch a ball. But their social abilities, their social cognition, their social intelligence is way down relatively, as you'd expect. That's a problem with autism. And as a consequence too, so is their daily living skills. They may be aged 3, but they're really developmentally more like a 2-year-old in what they can achieve. Now, there's another group of children with autism who actually also have what we call intellectual disability, that is developmental delay. Their capacities at their age is not what you would expect. In other words, their age development, their developmental age is below their chronological age, and that's represented by the green line. These are children with an IQ roughly of what we would say below 70, where 100 is the average and normal IQ ability. In other words, they're lower in all aspects, their thinking, their language, and their receptive language. Sometimes they might be somewhat better at something. This particular child is not too bad at their visual motor imitation, that is their ability to copy what they see somebody else doing, but they do also have an intellectual disability. And we need to know that with children with autism, because in that child, we're not only dealing with a child who has autism, but a child who has developmental delay or intellectual disability, and that needs to be taken into account. And this goes on throughout life. When the child gets older, we need to do a cognitive assessment to work out if, for example, in a very intelligent young person, whether they have some cognitive difficulties, for example, with the speed with which they process language and process what they hear people speaking to them. So this is another aspect of let's look at the whole child, not just their autism. Next slide, thank you. Now we need to look at their biology, their body and how it functions. Now, any child might have a medical condition. They could have asthma, they could have epilepsy, they could have problems with cerebral palsy, and they will complicate the fact that they might have autism. And in fact, we know in children with autism that they're at more risk than the general population of having epilepsy. And if that's not detected and not treated properly, well, then of course it will compromise how well they do, and it'll compromise their early intervention. So look out for associated medical conditions, and that's what the paediatrician is on the lookout for, and the general practitioner. A lot of children with autism do have problems with their motor skills. Some years ago, we did quite a lot of research which indicated that children with autism have difficulties with their gait. Their gait is odd and abnormal quite often. Some of these children can be very clumsy, even if they're very bright and intelligent, but still are on the spectrum. So clumsiness can be a problem, and later on that might transpose into difficulty with handwriting or difficulty with fine motor skills. And their posture can be just somewhat floppy or all over the place. Diet is a very important part of our life. We need to have a healthy diet to grow well. And quite a lot of children with autism, because they have difficulty with transitions, with moving on from one thing to another, with dealing with new things, with new experiences, can have problems with eating. They can be very fussy and they can have a very narrow diet, or they may have a diet which is responsible for sensory sensitivities. For example, they may not like the feel of crunchy foods in their mouth, so they'll avoid that. And certainly fussy eating and dietary problems are more common in children with developmental delay and with autism. Unfortunately, it's not transitory usually, and is quite often quite resistant to usual interventions. But the earlier we get onto it, the better able we are to steer a child at least into a more healthy diet, whilst respecting also their sensitivities to certain foods and textures. Another area with their bodies is their sleep. Many children with autism have very irregular sleep-wake patterns. We know that there might be a biological reason for this in their brain, in the way their brain initiates sleep and then keeps us asleep. Sleep's very important. We do all our growing and tissue repair while we're asleep. It's very important to have a regular sleep routine. And another issue with little children with autism is helping parents in early intervention to develop a healthy sleep-wake cycle with their child. And that can go on, in fact, to become a problem, for example, even in adolescents and adults on the spectrum, where poor sleep and an abnormal diurnal rhythm is a big problem for them. In other words, we need to look at the physical and health aspects of the child to consider the whole child when we're doing an assessment. Next slide, please. Another thing that children with autism can have is developmentally excessive emotional and behavioural difficulties compared to what is expected of a child at that age or level of intelligence. And this can take the form of tantrums or rages. Now, all 2-year-olds have tantrums and rages a little bit, but these are tantrums and rages that are excessive, they don't calm down, and they go off like a cracker at the least trouble. Or these children can be defiant and uncooperative. They won't help, they won't cooperate, they won't lift their body to have their trousers put on, and so forth. Or they can withdraw and become very isolated and very hard to contact. So in other words, these emotional and behavioural difficulties can take a number of different faces. Now, these difficulties are usually in response to communication problems. For example, the child's not understood and the child has difficulty understanding others. Now, you imagine for yourself, if you can't be understood and if you can't understand what others are saying, how frustrating that must be. And therefore, in early intervention, we must get on to communication difficulties straight away and give the child and parents better ways of communicating. For example, through not just using words, but using pictures. These tantrums and rages can also occur by changes in environment or a new event or activity. The child has a meltdown when a stranger comes to the house, or the child becomes defiant and uncooperative when their breakfast routine is altered, or the child withdraws and becomes isolated when, for example, their bedroom's tidied up and it's not the same as it used to be. We need to learn about this so that we can second guess and avoid this being a trigger for emotional and behavioural difficulties. I've already mentioned what problems these children have with transitions, moving on from one thing to another, and that certainly can prompt defiance and uncooperative behaviour. Sensory sensitivities can also cause these difficulties. For example, the child may have monumental meltdowns when it goes with mother to the supermarket or out shopping. And as soon as they're using ear-cancelling headphones, that behaviour may settle. In other words, they're responding to their distress about loud noises. And social challenges can also cause upset. Some children with autism, for example, at daycare, may get on fine with 1 or 2 children in their environment, but suddenly if there are 6 or 7 and it's mat time and they must sit down on the mat, they may become very upset, for example, withdraw or isolate or have a tantrum because they can't manage the social challenge. Next slide, please. These excessive emotional and behavioural difficulties are usually, almost always, in fact, a communication of distress and upset. And if we understand that, we can work with the parents. Early intervention can help avoid or ameliorate these problems and help the child calm down. If they're not managed with early intervention and parent support, these behaviours can escalate and lead the child to use these behaviours to control their environment and the people in it. With behaviours such as demand avoidance, they learn that if they avoid demand, they don't have to do what's upsetting them. Or they may develop oppositional and defiant behaviour, or they may become socially withdrawn and isolated. For example, a teenager may use that method to avoid going to school and remain at home in their bedroom doing nothing much except working on the screen. Next slide, thank you. So what are the key steps to positive behaviour for support for these children? Firstly, identify and track the behaviour, understand why the behaviour is occurring, develop a plan and act on it, change events that occur before the problem occurs, and encourage alternate behaviour and teach new skills. In a nutshell, that's behavioural management in an early intervention program for little children, and in fact for older young people for that matter. Next slide, thank you. Other emotional and behavioural difficulties that we see in children with autism are quite prevalent. The first of these is attention deficit hyperactivity disorder, which can affect, we think, up to 50 or 60% of children with autism. These symptoms of inattention, impulsiveness, hyperactivity persist, and they're developmentally excessive. That is, you wouldn't expect it of a child of that level. For example, 2-year-olds are very inattentive and impulsive and hyperactive, and they don't have ADHD. But even some 2-year-olds have more inattentiveness and impulsiveness and hyperactivity than you would expect. Next slide, thank you. This is a real problem. On top of the autism, inattentive behaviour may lead a child to miss social cues. It may result in them upsetting their peers. Their hyperactivity may hinder their participation in games and things that help them learn. And in fact, specific play behaviours have been linked with rejection, like being bossy or intrusive or inflexible or controlling. And these are all behaviours that children with ADHD can have. As a consequence, children with ADHD may be disliked within minutes of the initial social interaction, and then, of course, denied further opportunities to practice social skills with that group, and that leads to further rejection. In other words, ADHD really seriously complicates the presence of autism. Next slide. Why does it happen? Well, there are lots of causes for it. ADHD, sometimes environmental toxins in the developing baby might contribute. Exposure to alcohol and cigarette smokes during pregnancy, hormonal imbalance and pre and perinatal risk factors, and sometimes a genetic inheritance may contribute. A young parental age, a family history of smoking and stress are also associated with an increased for ADHD, but sometimes it can just occur out of the blue for no reason that we can easily detect. It needs to be assessed as part of the whole child. Next slide, please. Anxiety is another emotional and behavioural difficulty that young children with autism can have. At least 30 to 50% of children with ASD have impairments in social, school and family functioning that are due to anxiety. So therefore, it's very important that we pick it up so that we can intervene early, because anxiety interferes with social, academic and adaptive functioning. It gets in the way of development. Next slide, thank you. Why such high rates of anxiety? Well, because the child with autism has difficulty with regulating their emotion. They get anxious with change in routine. They get anxious with changes in expectation. They're apprehensive in social situations. They fear future change, and they have poor understanding of occurrences in their surroundings. If that was your world, of course you would get anxious. And as they get older too, there's an increased rate of mood disorders like depression. Next slide, thank you. How do we know the child's anxious? They can be distressed and agitated when separated from their family. They may refuse to go to preschool. They can have pervasive worries and fearfulness about everything, about it might rain, it looks like there are thunderstorms, what will happen this afternoon? They can be restless and irritable, or timid and shy and withdrawn. And actually, that's a feature of autism, isn't it? And so that becomes more prominent. They might become terrified of an object, not always something like a dog or a spider. It could be something like a soft toy or a puppet. They may have associated somatic symptoms like headaches or stomach pain, but not be able to connect that with their anxiety. Sleep is usually disturbed, perhaps with nightmares as well. Their concentration is impaired, and that reminds us of ADHD too, doesn't it? And some children relive stressful events in their repetitive play. They may crash cars together if they became anxious after being involved in a car accident, for example. Next slide, thank you. What can we do about it? Well, firstly, if we understand what might be making the child anxious, we might be able to do something to either avoid the anxiety situation for them, if that's safe and appropriate to do so. Certainly, we shouldn't avoid them going to school, but develop strategies to help them manage what it is. In other words, understanding the why is the first step in management. We need careful observation and understanding of the child's developmental level. For example, a child of 3 has different sorts of fears and worries than a child of the age of 16. We need to know what their communication abilities are like. If they really have difficulties with comprehension, then that is a source of anxiety, and we have to augment their communication, perhaps through the use of pictures. And we need to know about their profile of autism symptoms so that we can see how anxiety fits into that. Next slide, thank you. Management involves several approaches. We need to define the stresses. We can modify the environment. We can improve communication through visuals and timetables and picture scripts. We can plan for transitions, warn the child, give them a story, a little picture story about going on a holiday so they're prepared for it, or a transition plan in moving from home to preschool. We need to provide parent support because parents are the best therapists to help with a child's anxiety. Sometimes we use special treatments like cognitive behaviour therapy, which might involve relaxation exercises, role play, or graded exposure to fears. Stress debriefing as usual, that's where we use social stories of an anxiety situation so the child can be less fearful of it. And only as a last resort might we think of medication, and that would be something the paediatrician would be involved in, but only as part of a planned management approach. Next slide. So early intervention must respond to this range of social communication and behavioural and emotional difficulties, requiring a collaborative team, and I stress that this is a team effort, and part of the team are parents and family members and teachers and other professionals working together. And if that happens in early intervention, the outcome is much better than we might expect, and we can put a child with autism onto a trajectory to better development, to better mental health, and a better and brighter future as a full member of the community and our society. Next slide. Here it is said in another way. We need to take into account the child's biology, what their genetics are, medical condition and health, their intellectual abilities, psychological factors like their temperament, are they easy or difficult, the impact of life events on a child's psychology and development, and their social world. What are their family resources? Because if the family's in poverty or is homeless, then that's a very difficult situation for the family compared to one who is well off and not reliant on having nowhere to live. Parental and family stability is important. The parents' mental health. It's important for parents to look after themselves as a couple, if there is a couple, and their own mental health in order to support their child. And finally, all of the social support and provision that agencies can provide. Now, if you've got any further questions or worries about your child and need some help after this session, again, I encourage you to consult your general practitioner or talk to your maternal and child health nurse, or you could go online to the Mental Health Foundation helpline or one of the other kids' helplines. Reach out, don't be ashamed to say, is my child okay? I need some advice because I'm worried about something. Thank you very much.